Welcome to a new season of CLOT Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director. This season, we have a new addition to our team, Dr. Maha Othman from Queen's University in Kingston, Ontario. She will be joining Dr. Jameel Abdulrehman from Toronto General Hospital as co-host. We're excited to have her on board, along with Jameel, to lead the interview discussions. Welcome to both of you.
Great to be back.
Thank you. I'm excited to be joining the podcast.
In this podcast, we're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
In this episode, we'll be discussing a recent paper published in BMJ Open entitled Pilot Trial Study Protocol, Tinzaparin Lead-in to Prevent the Post-Thrombotic Syndrome Study Protocol.
And we are very pleased to have two of the co-authors with us today, Dr. Ilia Makedonov and Dr. Jean-Phillippe Galanaud. Dr. Galanaud is a general internal medicine specialist and thrombosis physician. He works as a staff physician in the Department of Medicine at Sunnybrook Health Sciences Centre in Toronto. He is also an associate professor of medicine at the University of Toronto, and his areas of research expertise are in post-thrombotic syndrome and DVT. He is currently conducting with Dr. Susan Kahn from McGill two multi-center studies in the field of post-thrombotic syndrome, one on the prevention with low molecular weight heparin, the TIO study, and one on the treatment with venoactive drug, the MUFFIN study. And Dr. Makedonov, who completed medical school at the University of Toronto, followed by internal medicine residency in Ottawa. He took a keen interest in thrombosis, doing a fellowship at Sunnybrook and receiving a grant from Can Vector. His research has focused on the post-thrombotic syndrome as well as distal DVT and cerebral venous sinus thrombosis. He runs a thrombosis clinic at the South Lake Regional Health Center. He has a broad clinical practice, including peripartum and cancer-associated thrombosis. And in his spare time, he bikes and snails, and he hopes to one day own a dog. Thank you both for participating in our podcast today, and let us get started with our questions. Perhaps if you can give us in the beginning some background on what is post-thrombotic syndrome.
Yeah, of course. I'll answer this one. So, to start with, post-thrombotic syndrome is a form of chronic venous insufficiency that's caused by a prior clot in the same extremity, same limb, same leg, and that caused by multiple different mechanisms, and they all come together to create venous insufficiency. One big mechanism is that the valves get damaged after a clot in the veins, and those are very important to prevent backflow of blood down the leg. And the bigger the clot, the more proximal it is, the more damage it's gonna bring to those valves. And of course, the more damage has been done, the less chance of that valve recovering, even as the clot recedes and goes away and dissipates. That's why we tend to see, the more proximal the clot, the iliac clots tend to have the highest risk ETS down the road. Other mechanisms are sometimes there is residual venous obstruction. So oftentimes clots, they scar down, they become chronic, but they don't fully go away in that scar tissue. And that, again, reduces venous return because now the size of the pipe is smaller, blood can't get up the leg as well. And all of that together leads to, again, venous insufficiency. And that comes out in many different ways, but some very common, presenting symptoms would be a patient coming in saying my leg is heavy. You can have that heaviness even without edema. So some primary care practitioners might not realize that there is actually the post-thrombotic syndrome. Sometimes the leg gets really itchy, heavy, itchy, painful, especially after standing or a long day on their feet. And again, that's some of the subtler points. It doesn't always have to have edema, but often edema is a big part of it. So the big swollen leg with lots of reticular kind of lacy hepatic veins, especially more prominent towards the ankle, lower down, that's the classic appearance. And as it gets more serious, then the worst form of it is venous ulcers, because those often are very hard to heal. You have to have really high quality home care, high quality wrapping, dressing, though often very difficult for patients to follow through on that. And then those can obviously become infected. You can get septic, but that's obviously a very small proportion of people with PTS, but that's the whole spectrum of what it can be.
So I fully agree with what Ilia said, and I would just like to add that, of course, post-thrombotic syndrome won't kill your patient, but it will make his life very difficult because post-thrombotic syndrome is very frequent. It can happen after a proximal DVT. We estimate the prevalence of post-thrombotic syndrome to be 20 to 40%. But it's the strongest predictor of impaired quality of life after a deep vein thrombosis. So it's something to keep in mind. Yes, it's not fatal. It won't be fatal, but it makes your life difficult.
One thing I would add to that, actually, is that, obviously, as Dr. Galanaud was saying, by the book, the incidence of it is 20 to 50%. But I do wonder now, anecdotally, if that's overestimated, because in clinic, definitely don't see it, in half of my patients, probably a bit less than that in real life.
Well, thank you, both of you, for this very comprehensive description. Clearly, it's a condition that affects the quality of life.
So there have been various attempts to decrease the risk of post-thrombotic syndrome, such as compression stockings or catheter-directed thrombolysis. Are these effective means at reducing the risk of post-thrombotic syndrome?
Yeah, so I'll take that one. So thanks for asking. So yeah, the classic teaching has been to, prescribe elastic compression socks to reduce the risk of developing PTS later on. And that was based on a number of kind of open label randomized trials that came out of Europe. The strong part of that data is that they were randomized, which is good. But the open label nature means that there was no placebo essentially. So people who were in the placebo in the non-SOC group, they knew they had no SOC. So that would definitely even subconsciously impact their assessment of their symptoms, because there's no actual intervention. That's what an open label trial is. So those trials showed a benefit. All of them did, these major European RCTs. And then there was a landmark Canadian, SOX trial. Lots of us are familiar with that. Dr. Kahn was in charge of that. And actually, it did not show any improvement of reducing actually the risk of PTS or preventing it with compression stockings. That was a bit disappointing to some of us, who believe in these treatments. Depends who you ask, how much stock people put in that. But some people, it was a big disappointment. The only caveat, so that kind of put the final nail in the coffin for people being very dogmatic about demanding their patients wear socks up front to protect them. But the only caveat to that is that the compliance wasn't that good to socks. So, only 55% wore the stockings more than 3 days per week. So some would argue that we need better patient buy-in for these trials, because again, the European trials had generally 80% plus adherence. So maybe it didn't work because people didn't use them. So that's kind of still a bit controversial because of that. But it seems to be not a silver bullet by any means. So it's no longer kind of widely recommended by most thrombosis physicians up front, again, to protect from PTS. The other interventions that you mentioned are catheter-directed lytics. No one does really systemic thrombolysis so far as I know, for just reducing the risk of PTS, because the risk of bleeding is very high. But people definitely do catheter-directed lytics, just kind of putting a catheter, in the appropriate spot next to the clot. There's been 3 major trials kind of focusing on that. Kind of chronologically, it was, CAVE-T, ATTRACT, and then CAVA. CAVE-T did have a reduction in PTS, but the other 2 did not. Putting it all together, there was a meta-analysis recently. It showed a relative risk of about 84 of developing PTS with catheter-directed lytics. So about a 16% reduction only in the risk of PTS. So it's not a major benefit. Seems to help more if the clot is larger and more proximal and more extensive. So those giant iliac clots, it's going to do more good for you than, you're not going to do it for just a popliteal clot pretty much because the risk of PTS is low. On the downside is that the relative risk of a major bleed is much, much, much higher than without catheter-directed lytics. Relative risk is about 2.03 from a recent meta-analysis. So it's about a 200% chance of major bleeding, only gaining a 16% reduction in risk of PTS. So it doesn't seem to be worth it for most patients unless the leg is really in bad shape. Again, with a large proximal clot. So I think most physicians don't tend to prescribe this or look into it for their patients that often, except for specific cases. Of course, if they have, phlegmacious, really indolence, that will be a different case altogether if there's compromised, viability of the tissue, but that's not for PTS purposes. So overall, to summarize, I guess the other interventions for preventing haven't really panned out, including compression socks, which is very ambiguous, like I described, and lytics only seem to work for the biggest of the clots for only a small percent of patients, because only about 9% of patients actually have iliac clots. The rest are all smaller downstream clots.
Okay, great. So now you made us very curious to hear about the TILE study. Could you tell us about it and what are the objectives?
Thank you. So the TILE study is an open-label, assessor-blinded, multi-center study assessing if a therapeutic dose of subcutaneous tinzaparin, a low molecular weight heparin, given for 3 weeks, followed by rivaroxaban 20 milligram daily, is superior to a conventional treatment with oral rivaroxaban, so 15 milligram BID for 3 weeks, followed by rivaroxaban 20 milligram daily, in preventing post-thrombotic syndrome in patients with the first episode of acute common femoral or iliac deep vein thrombosis. For the main study, the primary outcome will be post-thrombotic syndrome assessed at 2 years. And now we are currently doing a pilot trial, and we will assess post-thrombotic syndrome at 6 months. All patients will be treated with anticoagulant treatment for at least 3 months as per international guidelines, and we'll have follow-up visit at 10 days, 3 weeks, 3 months, and 6 months for the pilot study, and after 6 months, every 6 months in the main trial.
So with the lead-in of low liquid heparin, you said it would be 21 days. How did you decide on a 21-day lead-in with low liquid heparin?
Yeah, so good question. So a couple of reasons. One is kind of mechanistic. It's that we're trying to target the phase when the inflammation and the inflammatory response is the greatest, because the thinking, as we'll talk later, is that heparins have some anti-inflammatory properties. And the BioSox study did show that inflammatory response of all the markers is really the highest in the first about 3 weeks to 1 month. So that seems to be the time to target. You don't want to go too long because, patients will not want to take an injectable for too long. The second reason is that that's exactly the point that you switch from rivaroxaban from the twice daily dosing to the once daily dosing, 3 weeks. So it seems to line up on a pragmatic level with the rivaroxaban transition, as well as with the inflammatory response.
So the study is looking at low molecular weight heparin decreasing the risk of post-thrombotic syndrome. How would that work on a physiological level? What is the mechanism?
Yeah, thank you. Interestingly enough, heparins actually do have a long track record of having some anti-inflammatory properties, which has been, tested in different other illnesses too, not just clotting. Apparently, there have been applications to try it with inflammatory bowel disease, with inflammatory lung disease. So this is not a new concept. But more specifically, they're actually heparins are biologically derived products, so they do come from pig and cow intestines pretty much. So they presumably have some kind of function in there to protect the mucosa naturally, and they target many different parts in the pathway of inflammation that's really active in those first couple of weeks, and a clot as well. Just some examples, they inhibit the tissue factor pathway. They also block P-selectins, which are all kind of pro-inflammatory molecules. They inhibit lymphocytes that are working around the clot, chemokines, they decrease fibroblast proliferation, endothelial activation. And animal models, kind of moving down from just lab data to animal models, they also corroborate that because clots seem to be smaller when you expose them to low molecular heparins. There's less extravasation at the clot site, suggesting the inflammatory response is not as great around that clot. And they also accelerate the formation of new endothelium, which again protects those valves and kind of makes that vein heal faster. And they reduce fibrosis, which is scar tissue, which we don't want because, again, that leads to residual venous obstruction. And lastly, there seems to be actually even a dose response effect, so which suggests that it's actually some biologic response as opposed to, more of a coincidence. If you guys are interested, there was a very comprehensive review on this that we also put out on the biological mechanisms of inflammation. Came out a couple years ago. You can find it with our names. But yeah, definitely to recap, multiple pathways are blocked, and they seem to be possibly more active in terms of anti-inflammatory properties than DOACs. There's more research on them for sure. The last point to raise, it kind of focuses on why we chose tinzaparin. There was just one theoretical, again, lab research paper, wasn't clinical, but it was Stella Salta in 2018. They compared kind of different DOACs and different anticoagulants, and tinzaparin did seem to have a bit more anti-inflammatory properties by inhibiting thrombin more than the other comparators, kind of delaying clot formation and also reducing the maximal clot firmness. So that seems to be the basis for this specific low molecular weight heparin that we chose.
So what did prior studies show regarding the use of various anticoagulants on the risk of post-thrombotic syndrome?
I'll kind of break it down into two parts. First, I'll talk about low molecular weight heparins, then I'll talk about DOACs. And all of these studies, the comparator tends to be kind of warfarin because that has been for a long time the gold standard. And the last thing to know, there sadly isn't any head-to-head comparisons between PTS rates and low molecular weight heparin and DOACs. That's kind of the one big hole in the data. But starting with low molecular weight heparin, there have been kind of, again, a few studies, but only about four big ones had clinical outcomes. A few of them focused just on the ultrasound findings that I talked about, but four big ones talked about the actual rates of PTS and heparins compared to warfarin. The biggest one was the HomeLight study by Hall, actually came out of Canada in 2009. The good thing about that study, it was a multi-center RCT, and again compared tinzaparin actually at a full therapeutic dose for 12 weeks to a vitamin K antagonist. It had a very good, I would say, in this field, a good patient size. There were 480 patients, 240 in each arm, and it found a significantly reduced risk of PTS, odds ratio of 0.77, which again, that way even seems to be better than catheter-directed lytics, just comparing those two numbers alone at 12 weeks for reducing the risk of PTS. It was significant. There was some surprising, really strong findings, like the rate of ulcers was 0.5% in the heparin group compared to 4.1 in the warfarin arm, and that was, only at 1 year. So that was an interesting, kind of very optimistic finding. But the other studies have also been there. A lot of them weren't significant. Some had kind of clinical scales that we don't use as much, but this was the biggest one, the HomeLight study. But it definitely serves as a big foundation for our work. In terms of now the DOACs for reducing the risk of PTS, there's a lot of data there, but it's very low quality for the most part. By that, I mean, it's kind of retrospective studies. There's lots of registry-based studies that kind of pull codes from, health insurance databases, and, diagnosing PTS with a code is very hard because how do you know it's not baseline venous insufficiency, especially by the time it gets to the coding people. So that's kind of a lot of people studies are based on that. There's some the most promising study, I would say, as far as DOACs and PTS reduction. It just came out a couple years ago. Let me find it. Yeah, so RSA Al, it came out in 2019. It was actually the first randomized trial of just looking at DOACs for preventing the risk of PTS compared again just to warfarin. But it had a remarkable result, I would say. The rate of PTS was 29% in the warfarin arm and 9% only in the DOAC arm. So that was very impressive. And the other interesting thing is they had very good control of the INR in their group. So you can't blame, people being subtherapeutic for the high rates of PTS. So definitely DOACs seem to be getting more and more studies on reducing the risk of PTS, but not yet as many trials as low molecular weight heparins have.
Thank you. So this is a pilot trial. Can you tell us what that means and the importance of pilot trials in general?
So a pilot study is a small study to test research protocols, data collection instruments, sample recruitment strategies, and other research techniques in preparation for a larger study. A pilot study is one of the most important stages in a research project and is conducted to identify potential problem areas and deficiencies in the research instruments and protocol prior to implementation during the full study. For TILE, the main reason to conduct a pilot study are to assess if the study is feasible in terms of recruitment and to assess the magnitude of the difference in the rates of PTS in each group to determine the sample size of the future large-scale study.
So we had talked about open label studies before in which the participants are aware of which study arm they're assigned to. The challenge with that is that with subjective outcomes, it might bias their awareness or its presentation of the symptoms. So the TILE study is open label design. Are you taking any precautions to account for this?
Yes, it's true that the gold standard in such research would have been to conduct a double-blind trial, but it's much more complicated to do. And we have to keep in mind, because it would mean that doing a double-blind study, that patients will receive an injectable placebo, so they will receive an injection that they that could not, for nothing on a practical point of view, because they are not getting the injectable low molecular weight heparin. But we have to keep in mind that in TILE, the PTS assessment, which can be prone to a placebo or rather an injection effect, will be assessed at 6 months in the pilot study and at 2 years in the main study, which is long after the patient have been treated with tinzaparin, which means that it's very likely we expect that the patient will have forgotten that they were receiving injection for 3 weeks more than 5 months ago. And furthermore, also investigators who will assess patients for clinical signs of post-thrombotic syndrome will not be aware of patient treatment arm, which will limit such a bias that we are not double-blind.
Yeah. And it is a multi-center study, so we're curious to hear from you. What are the challenges of conducting such a multi-center study?
So the main challenge is that we need to enroll patients at the very acute phase of their DVT, when inflammation is at its peak and when low molecular weight heparin are the most likely to be more effective when there is a lot of inflammation. So we need to enroll patients that have started to be symptomatic on a DVT standpoint for less than 10 days. Furthermore, the enrollment window is very short after the DVT is diagnosed, because we do not want patients to receive for too long other anticoagulation treatment than the study drug. Patients need to be randomized no later than 72 hours before being started on anticoagulant. Furthermore, most patients are not aware nor do not realize how devastating post-thrombotic syndrome can be in the very long term. Most of them have never heard about post-thrombotic syndrome. And some of them may be scared about receiving an injection or are scared about injecting testing themselves, and they may prefer being treated with an oral medication than receiving an injection because they are not aware of what is post-thrombotic syndrome and because they may be scared of receiving an injection. So that's the main challenge that we have in the TILE study.
Yeah, I see. Well, one of the things you listed in the protocol is that 2 patient partners were involved in the design and conduct of the trial. Could you explain to us the value and contribution of patient partner engagement in these types of studies?
Also, participation of patients' partner is essential in research because thanks to their own experience, they always make some critical suggestion when we design the studies. They are able to say, oh, there are too many procedures. Patients won't attend this procedure. It's too complicated. It's too burdensome. Furthermore, when we develop the patient's material, they are able to help us to say, oh, it's too complicated. It's not written in lay language. And so they make some critical suggestion on how to write the patient's material. For the TILE study, we have the great chance of having Mr. Christopher Dennis and Mrs. Jessica Zambito as patients' partner, and their contribution to the study is just fantastic. I don't think that conducting research nowadays without patients' partner is a good thing because it's so great to have them on board.
Fully agree.
All right. So is there anything that we haven't discussed today that you would like to add?
Yes, so with Susan Kahn, who is co-PI of the project with me, I would like to thank all the people that are helping us in this project. For sure, Ilia, Dr. Makedonov for helping in publishing the protocol and the literature review. All the centers that are participating in the protocol and their study personnel. We have on board UHN, McMaster, Ottawa Hospital, the Jewish General Hospital, and Sunnybrook, the Kahn Vector Network and Thrombosis Canada for their invaluable help in promoting the study, as well as Leo Pharma with the special thanks to Randall Leader for supporting the study, and of course, all the patients that have agreed to participate so far in the study. Thank you very much to all of them.
Well, thank you both so much for educating us about this interesting study. And thanks, Jameel, for co-hosting this podcast with me. And I'm so excited to be doing this for the first time.
Yes, thank you to both of you and to David for doing this very nice podcast.
Well, and thank you everybody for participating today. And I want to thank our listeners for tuning in to CLOT Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. And if you have any recommendations for future podcasts, ideas about topics or papers, please send them to us at info@thrombosiscanada.ca. And please subscribe to this podcast so that you're notified about the release of new episodes. Check out the 22 episodes we've already put in the can, so to speak. And don't forget to check out our website for education programs, clinical tools, and guides. And also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Thanks, everybody, and have a great day.
Thank you.